morning, Chairperson and my dear delegates. So I am going to present a paper on a novel technique, that is efficacy of less invasive modified O-arm navigated delta fixation in high-grade osteoporotic spondylolisthesis. So about 19% of all spondylolisthesis cases are high-grade, and literature suggests surgical management for the same. And there are variety of surgical options available, like anterior, posterior, posterolateral, circumferential fusion in a single or a stage manner. In 94, Abdu et al. Described pedicular transvertebral screw fixation, which proven to be simpler and effective modality. In 2018, Fernandez et al. Described navigation-guided transdiscal fixation, and we introduced less invasive modified O-arm navigated delta fixation, that is a LIMO Dalta technique. Our objectives is to introduce this novel technique to study operative parameters in the form of incision length, blood loss, operative time, and complications, to study pre and post-operative spinopelvic parameters, to study functional outcome in the form of COMI ODI VAS score. It's a prospective study performed in 2020-21. 10 patients of osteoporotic high-grade spondylolisthesis were included. Our inclusion criteria was Meerding grade 3 or more and SDSG grade 4 and 5. Advanced stage of disc resorption, that is reduction of disc height of more than 75%, chronic low back pain and or radicular pain, restored global sagittal balance, and T-score of -2.5 or less. This is the SDSG classification we use. Moving on to the surgical technique, with standard prone position, we mark the level. Then we attach the dynamic reference array to a cranial spinous process. Then with the help of navigated instruments, we do verify and we check the accuracy. Then this is planning of the transdiscal screw trajectory. Then we plan the trajectory of the transdiscal screw with the help of navigated probe, which we keep on the skin, which help us to locate the incision for transdiscal screw, as you can see in the image. And then 2 paraspinal around 1 centimeter incisions are taken. Then we follow the standard steps. We use the navigated Lenke. And in these steps, we have to be careful to avoid the neural foramina to avoid neural injury. And then navigated tap, followed by we assess the length real time, and all these steps are performed under vision. Then we insert the cranial screw in same standard fashion. The post-operative protocol in our study was, patient was mobilized on day 2, and till that in-bed exercise were given, and we recommended half TCO for 6 months, and 3 monthly follow-up was done. The results were the male to female ratio was 1:9, mean age was 62, mean T-score was -2.7. All cases were lytic and Meerding grade 3. The level for 7 cases were L4-5 with sacralized L5, and 1 patient had additional bilateral pars lysis where the level of fixation was L3-5, whereas other 6 cases level of fixation was L4-5 and 3 cases were L5-S1. The mean surgical time was 138 minutes, mean blood loss was 100 ml, surgical incision was 5 to 6 centimeter midline and 2 paraspinal centimeters. There was no any intraoperative complication observed. The functional outcome was statistically significant for VAS, ODI and COMI score, whereas the radiological outcome for spinopelvic parameters was not statistically significant. 1-year follow-up CT scan in all patients show monoblock interbody and intertransverse level fusion, as we had done intertransverse level bone grafting for all the patients, and we haven't done any interbody work. So there are multiple procedures and options available for high-grade spondylolisthesis. Posterior instrumentation, reduction with interbody fusion, with in situ posterolateral fusion or transdiscal screw are the usually followed techniques, but they have their own pros and cons. So posterior instrumentation reduction is usually advised in unbalanced spine, whereas balanced spine and pelvis can get benefit from in situ fusion. The maximum strain on L5 root is in the second half of reduction. Posterior instrumentation with in situ posterolateral fusion comes with pseudoarthrosis, slip progression, cosmetic deformity, but there is definitely less risk of neurological complication. It avoids distractive forces on pedicle, prevents screw cutout, and it's technically less demanding. The transdiscal screw is recommended in high-grade spondylolisthesis with restored global sagittal balance and advanced stage of disc resorption. Our study, we included high-grade spondylolisthesis, balanced spine, osteoporosis, and there was minimal blood exposure, blood loss, surgical time, which improved the post-op recovery, enhanced functional outcomes, and showed monoblock fusion at 1 year. These are the demonstration of the cases. There was no significant spinopelvic parameters changes, and this image showing post-op 1 year CT with signs of fusion. This is case 2. So you can see the post-op CT after 1 year showing fusion along the track of the screw and intertransverse level. Case number 3. So there was fusion observed here as well in the intertransverse and along the track of the screw. This is the clinical. So limitations for our study was small sample size, shorter follow-up, and high cost of O-arm navigation setup. The LIMO Dalta technique is newly modified version of conventional transdiscal screw preferred in osteoporotic high-grade spondylolisthesis with balanced spine, minimal incision, decreased blood loss, operative time, 3-column rigid fixation makes this novel technique simpler, safer, and effective. Thank you.